Your patient is on a maximum sedation, propofol, midazolam, fentanyl, but they're still fighting the ventilator. Their blood pressure is crashing, and you're running out of options. Then someone mentions ketamine, and half the team says, absolutely not, while the other half says it could save them. If you don't know why ketamine is becoming the game-changing sedative in ICUs worldwide, this video could revolutionize how you think about critical care sedation. Hey everyone, welcome back to another critical care lesson. I am Neil Brian Galvin and this is NurseBrain, and for today, we're diving deep into one of the most controversial yet revolutionary medications in the ICU, ketamine. Here's what's shocking. Ketamine was developed in 1962 as an anesthetic, but it's taken us over 50 years to realize its incredible potential in critical care sedation. And the results? They're absolutely mind-blowing. In this video, I'm going to reveal why ketamine is becoming the go-to sedative for the sickest ICU patients, the three game-changing benefits that no other sedative can provide, and monitoring secrets that separate expert ICU nurses from everyone else. But first, let me share something that will completely change how you think about sedation. A massive multi-center study of 390 ICU patients showed something incredible. When ketamine was added to sedation protocols, patients spent 78% more time in their goal pain range and needed 40% less opioids. But here's the kicker, their delirium rates didn't increase. This flies in the face of everything we thought we knew about ketamine. For decades, we avoided it in the ICU because we thought it could cause hallucinations and worsen delirium. Turns out, we were completely wrong. I have been working in critical care for more than half of my entire career, and I've seen the transformation firsthand. Patients who were impossible to sedate with traditional agents suddenly became manageable with ketamine. But here's what they don't teach you in nursing school about why this works. Let's start with why ketamine is unlike any other sedative you've ever used, because understanding this will completely change your approach to critical care sedation. Ketamine works by blocking NMDA receptors in the brain, but here's the part that'll blow your mind. It doesn't suppress respiratory drive like opioids. It doesn't cause hypotension like propofol, and it actually has bronchodilator effects. Think about your typical sedation cocktail. Propofol drops blood pressure, benzodiazepines cause respiratory depression, and opioids slow breathing. Ketamine, it can actually increase blood pressure and heart rate while providing excellent analgesia and sedation. But wait, there's more. Ketamine doesn't just hit NMDA receptors, it also affects opioid receptors, monoamine receptors, and even has anti inflammatory properties. It's like having five different medications in one drug. Here's the game changer. At low doses, we're talking zero point 0.1 to zero point 0.5 milligrams per kilograms per hour, ketamine provides analgesia without the dissociation effects. This is called subanesthetic dosing, and it's revolutionizing ICU care. Now, let me walk you through the three benefits that make ketamine a game changer in critical care. Pay close attention to benefit number two. This one could save your patient's life. Benefit number one, opioid sparing effects. In that multi-center study I mentioned, patients on ketamine needed 40% less morphine equivalents. Think about what this means. Less respiratory depression, less constipation, less tolerance, and less risk of chronic opioid dependence after ICU discharge. I've seen trauma patients who were on massive fentanyl drips suddenly become manageable with half the dose when we added ketamine. It's like having a morphine multiplier. Benefit number two, hemodynamic stability. This is where ketamine shines compared to other sedatives. While propofol can drop your patient's blood pressure by 20 to 30%, ketamine often maintains or even increases it. For your septic shock patients who need deep sedation but can tolerate hypotension, ketamine could be the difference between needing three vasopressors versus one. Benefit number three, preserved respiratory drive. Unlike opioids and benzodiazepines, ketamine doesn't suppress the respiratory center. This means your patients can maintain spontaneous breathing efforts, making ventilator weaning easier. I have seen patients successfully extubated while still on ketamine infusions, something you'd never attempt with high-dose propofol or midazolam. Let me walk you through the five scenarios where ketamine becomes your secret weapon in the ICU. Scenario number one, the difficult to sedate patient. You know this patient, max out on propofol, midazolam, and fentanyl, but still fighting the ventilator. Adding ketamine can provide that extra sedation without that hemodynamic compromise. Scenario number two, hemodynamically unstable patients. Septic shock, cardiogenic shock, and a patients who need sedation but can tolerate hypotension. Ketamine's sympathomimetic effects can actually help support blood pressure. Scenario number three, status asthmaticus. Ketamine's bronchodilator effects make it perfect for intubated asthma patients. It provides sedation while actually helping open their airways. Number four, alcohol withdrawal. Some centers are using ketamine as adjunctive therapy for severe alcohol withdrawal, especially when benzodiazepine requirements become dangerously high. Scenario number five, chronic pain patients. Patients with chronic pain who are opioid tolerant often need massive doses for adequate analgesia. Ketamine's NMDA antagonism can help break through that tolerance. Now, let's address the elephant in the room, the safety concerns that make some providers hesitant to use ketamine. Emergence reactions and hallucinations. Here's the truth. At the low doses we use for ICU sedation, emergence reaction occurs in less than 5% of patients, and most of these are mild and easily managed. The key is proper dosing and not stopping the infusion abruptly. Gradual weaning prevents most emergence issues. Increased secretions. Ketamine can increase oral and respiratory secretions in about 14% of patients. But here's the thing, most ICU patients are already intubated, so this is easily managed with suctioning. If it becomes problematic, a small dose of glycopyrrolate usually solves it. Cardiovascular effects. Ketamine can cause hypertension and tachycardia, especially in the first few hours. In the study, 24% of patients experienced hypertension, but this was generally well tolerated. Here's your monitoring protocol. Blood pressure and heart rate every 15 minutes for the first hour, then hourly. Watch for signs of increased secretions. Monitor for any emergence phenomena during weaning. This is where the rubber meets the road. How to actually use ketamine safely and effectively in your ICU patients. For continuous infusion, start low, zero point 0.1 to zero point 0.2 milligrams per kilograms per hour. You can titrate up to zero point 0.5 milligrams per kilograms per hour based on response. Some centers go higher, but that's where you start seeing more side effects. For bolus dosing, zero point 0.5 to 1 milligram per kilogram can be used for procedures or acute agitation. Here's the secret most places are using. Ketamine isn't replacing your other sedatives, it's enhancing them. Think of it as the fourth pillar of sedation alongside propofol, benzodiazepines, and opioids. A typical protocol might be reduce your propofol by 25 to 50%, reduce opioids by 30 to 40, and add low dose ketamine. The synergistic effects are remarkable. Never stop ketamine abruptly. wean by 25 to 50% every 4 to 6 hours while monitoring for emergence reactions. Most patients tolerate this well, but have a small dose of midazolam ready just in case. So, there you have it. Everything you need to know about ketamine in critical care. Let me recap the game changing points. Ketamine provides analgesia and sedation without respiratory depression or hypotension. It's perfect for hemodynamically unstable patients and those difficult to sedate with traditional agents. The key is low dose, continuous infusion, proper monitoring, and gradual weaning. In that multi-center study, patients on ketamine had better pain control, needed fewer other sedatives, and had no increase in delirium. That's a win-win-win for patient outcomes. But here's the thing. Ketamine isn't just another drug to add to your arsenal. It represents a fundamental shift in how we think about ICU sedation. We're moving from knock them out to keep them comfortable while preserving function. If this video opened your eyes to the potential of ketamine in critical care, smash that like button and subscribe for more cutting edge contents that's changing the ICU landscape. And here's my challenge to you. The next time you have a patient who's difficult to sedate or hemodynamically unstable, ask your team about ketamine. Don't just accept that's how we've always done it. Be the nurse who advocates for better patient care. Speaking for revolutionary ICU medications, you absolutely need to watch my video about ICU drip sedations. Click here to watch it now. Thanks for watching, and remember, in critical care, staying current with evidence-based practice isn't just professional development, it's patient advocacy. Once again, this is NurseBrain, inspiring greatness one lesson at a time.